Welcome to the JOMA podcast, presented by the Jewish Orthodox Women's Medical Association. Every week, hear from expert medical professionals as they share up-to-date insights on health topics to help you live your best life physically, mentally, and emotionally. Join us as we navigate the ever-changing landscape of healthcare and strive to improve the health of the Orthodox Jewish community.
Welcome to the JOMA podcast. I'm your host, Dr. Jenny Berkovich, board-certified pediatrician and director of education for JOMA. This episode is all about environmental allergies. I think it must be allergy month here at JOMA. My guest today is the wonderful Dr. Rachel Schreiber. She graduated from University of Maryland's General Honors Program, completed a research fellowship through an intramural research training award at the National Institutes of Health, and then went to medical school at the University of Maryland. She completed her internal medicine internship and residency at the University of Pittsburgh Medical Center and her allergy and immunology fellowship at UPMC Children's Hospital of Pittsburgh. After practicing allergy and immunology in Pittsburgh, Dr. Schreiber moved back to her native Maryland in 2005 and has been practicing in the area since then. She opened Schreiber Allergy in 2015. Dr. Schreiber has worked with multiple media outlets, including the web, print, publications, radio, and local and national television to educate the public on practical medical issues. This episode is sponsored by Tovito. Use JOMA 10 for $10 off your Tovito membership. It is an amazing way to bring wholesome content for your whole family into your home. I hope you enjoy the episode.
Hi, Dr. Schreiber. Welcome.
Thank you.
So it's allergy week here, I think, in JOMA. We've had a lot of talk about allergies, and I had a guest I was sharing offline with you previously. I had a guest recently. We talked about food allergies. One thing that I said at the time was, as a general pediatrician, like, I took allergies seriously, but definitely not as seriously as when I became a parent to like an allergic child.
Right.
And so my perspective really changed. And so we kind of had a whole conversation about food allergies. But the truth is, most of what I see in my practice is actually not food allergy related. So I want to start the conversation there and talk a little bit about, at the very least, like most common non-food allergies that kids have.
So I would say most common non-food allergies are environmental allergies, right? So that's what causes allergic rhinitis. So that's like allergy to dust mites or pets or pollens or molds, all those things you can become allergic to. Now, a lot of times parents will say to me, my baby has such a runny nose. I'm worried that the baby has allergies. Babies in general, you need to be alive a long enough time to actually develop allergy to things in the air. So a lot of times if a mom comes to me and the baby has been in daycare, my first thought is more likely that's sort of recurrent viral infections as opposed to environmental allergy. Now, in my most allergic kids, I do pick up environmental allergy when they're really young, but that could be like something that the child has seen since birth. So like a dust mite or a mold or a pet. Family pets can be common allergens. You have to be alive enough seasons to go through the seasons to get seasonal allergy. So for example, probably in your first year of life, you're not going to have oak tree pollen allergy, right? Your first year of your life, you see the oak tree pollen. That's the first time you see it. And then you see it again in your second year of life. And as the years go on, your system kind of can get primed, and then you can develop that kind of seasonal allergy over time.
Is there an age where we should start thinking about seasonal allergies? It happens to be, I had a baby recently, and the parents were asking about allergies, and I kind of told them the same thing. It's too young. And I'm just thinking in my own practice, I sometimes start thinking about it in toddlers, but usually it's like school age kids where it really becomes something that I'm considering. Is that the correct approach?
Yeah, I think that's a correct approach. I mean, usually around actually age 3, my most allergic kids will start to present. And a lot of times those little guys will have like eye symptoms, itchy, watery, puffy eyes. They look really swollen. They come into the office, and when we look in their noses, the turbinates inside their nose actually will have a pale look. You don't look red when you have allergy. They look pale. And so pale, boggy, and then the eye symptoms, especially in the little guys. Then when they're around 4 and 5 and they're starting kindergarten, then I'm like, then even more of them will come out. But, allergy literally can come at any time. It can come, in your 50s. it can come literally anytime.
Parents love asking me to test for allergies. And I have some mixed feelings about this. I generally, when we're talking about environmental allergies, will discourage testing because I say, listen, if we know if you're allergic to, dust mites or pollen or whatever it is, it's not going to give us any more information about how to change your behavior. You can't really avoid those things. So let's focus on treating the symptoms. But sometimes parents are adamant and I'm kind of stuck. Is there any benefit to testing for environmental
Yeah,
allergies?
Jenny, I do think there is. So I always say to parents, how are we going to use this test, right? So I agree with you. I am not interested in testing a child or an adult unless I'm actually going to use the test. How does it inform our decisions? So in the case of a child, let's say the child has recurrent ear infections. Sometimes we actually test for allergy. We do a very limited panel if it's a younger child, like just year-round stuff, to see is there allergy that could be contributing to chronic inflammation and therefore those ear infections. So it helps us figure out, do we need to put the kid on antihistamine or a nasal spray, or, could we do some intervention or treatment to help prevent those kinds of infections? And similarly, if you have a child who you're suspecting year-round allergy, you suspect that child has year-round allergy or even seasonal allergy, it helps me figure out when you should take meds and how aggressive we need to be. If you have a huge, a lot of stuff, then I may be more aggressive versus less aggressive. But really, I decide on treatment based on symptoms. So if you have an oak tree pollen allergy, going back to the oak tree, because I'm in DC and in Washington, oak tree is very, very prevalent in our area. So if you have that kind of allergy, you want to start on your medication before the season begins. So there are things you can do. And let's say you have dust mite allergy. There are dust mite controls that we can put in place. There are environmental controls that we can put in place that can actually be extremely helpful. So I use those tests to help me recommend some environmental things that families can do, and also medications, when to start the medications, what to give. So it is useful, I believe.
Okay, I like that perspective. That makes a lot of sense to me. I'm curious if there is any technique or anything that parents can do to prevent environmental allergy development. I'm thinking of this again from the food allergy conversation that I had recently. Like we talked a lot about early introduction of allergic foods and how that can lower your risk. Does the same hold true for environmental allergies?
So it's a great question. And I always say this is the $1 million question in allergy, right? Like, how do we prevent food allergy? How do we prevent environmental allergy? The hygiene hypothesis is basically that we live in a cleaner society. We need our cleaner society. We need our vaccines. We need our clean water. We need all this stuff. But there's this theory that because we have this cleaner environment, maybe that is why our immune cells sort of skew towards becoming more allergic from less allergic. So, I mean, I'm a great proponent of vaccines and washing and hand washing and all that good stuff. We need all that to stay healthy, but it's possible that that has affected our immune systems. And we are more allergic now, that our immune cells needed something. They don't want to sit idly by. So they sort of develop an abnormal response to things that they should perceive as normal. So there have been studies looking at, for example, children who grow up on farms.
That's so funny that you say that, because I feel like and I wonder if this is maybe why, because I've read this study, but whenever I hear about this theory, this image pops into my head of people who live on farms who like send their children out to like roll in the mud, literally. Right. And those kids are like presumably less likely to be allergic than, my daily bathed, hand washing obsessed little 2-year-old. But yes, please continue. I'm curious what.
Yeah, no, you're exactly right. And it's maybe it's the mud, and it's also the endotoxins. It could be bacteria that, the animals have that the kids get exposed to that help them sort of develop a more robust immune system in some way. There have been studies looking at pets. Cats in the home are not protective. And cats, by the way, in general, are very allergenic. And dogs, but you have to have more than one dog for it to be protective in your own home, interestingly.
Okay. So what I'm hearing is not necessarily anything that you can do to prevent right, allergies developing, but maybe something to kind of consider as you're looking at ways to balance making sure that your kids are like right clean and healthy, but also I
Yeah.
guess not too sterile.
Right. Well, we also know that there's certain things that can happen like when during birth and also right after that can be protective. So actually having a vaginal delivery is protective for the baby because as the baby goes through the birth canal, they see that natural flora and that can help. Breastfeeding can help. But you know what? You don't always have control of this, right?
Yeah.
Like if you need a C-section, if you can't nurse, whatever it is, there's only so much we can control in life. So, even if everything quote goes right, you have a vaginal delivery, you're breastfeeding the baby, you can certainly develop allergy. We know that this is genetic. We know allergies are genetic. We know there is an environmental component. And I'm going to just throw in like a little fun fact here. I have to talk about this for a second about food allergy. Food allergies, when we talk about environmental components, are interesting because there are people in different areas of the world develop different allergies. For example, peanut is more common in America and in the UK. Actually, sesame is more common in Israel. Fish is more common in Japan. So there is some sort of geographical influence that we do not fully understand.
Fascinating. If
Mm.
if I had to take a test where I had to like guess where these allergies are the most common, I would think completely the opposite, right? We know that in Japan, I think, right, fish is like a much more of a common staple, right? Sesame's everywhere in Israel. Peanuts, yeah, I don't know. I guess yeah, we eat a lot of peanuts here. So I would think the exact opposite
I
because we
know.
have exposure, we're protected, but it
I
sounds like
know.
that's not the case.
Like there's so much we do not know about food allergy and environmental allergy. As many years as we've all been studying it and dealing with it, there's still a lot to be learned.
Oh, interesting. Okay. I want to talk a little bit about treatment. So
Yes.
I think for many years, all I really had in my pocket was antihistamine and one antihistamine, and not this one. Let's try another one. And there's a first generation and a second generation. I think now things are evolving. Talk to me a little bit about treatment options for environmental allergies.
Okay, so first of all, in general, medicines that are first generation antihistamines like Benadryl and hydroxyzine, we are really not using very much of at all anymore. In fact, I would say I 0% of the time recommend Benadryl for treatment of environmental allergies.
I just want to really emphasize that because I think that's really important. People are shocked that
Yeah,
this is the recommendation. I also have shied away from Benadryl. I think really for anything,
yeah.
it's really not recommended anymore. But it's still, I don't know if it's just still like very just prevalent in drugstores or policies like haven't caught up with this recommendation. Why, I don't know, why is it
I
still even, what is there
I
any
don't know.
utility to it?
Well, it is very prevalent in drugstores. You're right. And there's a lot of like name recognition that goes along with
Yeah,
Benadryl,
they have a
right?
great lobby. I think the diphenhydramine lobby must be doing something right.
Right. I agree with you. And just it's almost generational, right? It's been around for so long, so many people know about it. Um, I will use it like for some cases if you're having an acute severe allergic reaction, but really that is the drug of choice is more of a second generation antihistamine like Zyrtec, Claritin, Allegra, Xyzal, and all of these medicines, Jenny, are over the counter now. And so it makes it a little harder, to be honest, when patients come in to see me because I'm like, what are you taking exactly? Right. I want to know exactly what you're taking, exactly how much. We don't prescribe those drugs anymore. So it's always helpful when people know exactly what they're giving their children or what they're taking themselves. And it's also tricky because there are generic versions of these drugs that are, over the counter, they're easily accessible. And so I would say if you're prepping for a visit, just know what you're taking or what you're giving your child. So your physician knows how to manage that. Because sometimes the patient thinks that they're on 10 milligrams, that they're actually on 5 milligrams, and then we can push that dose, So it's important to know exactly what you're taking. So antihistamines are one way we treat. Nasal sprays are another. Steroid nasal sprays are like Flonase, Nasacort, Nasonex, Rhinocort. These are all also over the counter. That's kind of a mainstay of treatment in allergic rhinitis. And there are even antihistamine nasal sprays also now over the counter. There's an antihistamine nasal spray called Astapro, and that's also available over the counter, but also by prescription. We can still prescribe that one.
What's the biggest mistake, or would you say, that people make when they start treating allergies by themselves? The thing I see the most probably is underdosing the antihistamine. And I'm not encouraging people to go out and like start giving their kids more or taking more antihistamine. But I'm curious if there's like kind of like a common error that you see by the time families get to you and you see their sort of like at-home regimen.
Yeah. So first of all, I worry about polypharmacy, right?
Okay.
I worry about overdosing, like how much are you taking? Because again, all this stuff's over the counter. I see that probably less than underdosing, as you said, because people actually, how do you know what to take unless your doctor has told you, right? So yes, that's a lot of what we do, is figuring out what are you actually taking? Can we push those doses? Do we need to be more aggressive or do we not? Like I always go by the theory that less is more. So if you're controlled, that's great. That's perfect. I don't need to do anything with your dosing. Now, if you have a lot of environmental allergy, let's say you have a big tree pollen, I would say burden, I would want to push your doses. And sometimes it's not enough. Sometimes medications are not enough. And that's when we think about immunotherapy. So my sort of motto about immunotherapy, which is also known as allergy shots, is if you can't take meds, if you don't want to take meds, or if the meds don't work, then we think about desensitization. And there's two ways that we can desensitize. One is through shots, allergy shots. That's called subcutaneous immunotherapy. And then the other, my office offers sublingual immunotherapy, is what we do for environmental allergies.
But I'm thinking, wait, immunotherapy for dust, for pollen, how does that work?
For environmentals, we offer the shots, which is subcutaneous, and we offer sublingual, and that's for environmentals. But as an aside, we also do sublingual for foods. By the way, that is available.
Whoa. Okay. I will have a follow-up question on that. Okay. What is sublingual and how does it work?
So sublingual, let's take the environmental sphere first. Yeah. Anytime I'm making an order for your immunotherapy, whether it's for your shot or it's for sublingual, I'm looking at what I tested you to. I'm looking at your results and I'm taking those results and making a serum based exactly what you're allergic to. Okay. So it is a completely customized therapy. When I look at your results, I actually measure how big the skin test result was. So I know, okay, you're very allergic to dog. I'm putting a lot of dog in your serum. Okay, you're not allergic to molds. That's not going in at all. You have some allergy to maple tree pollen. I'm going to put a little bit of maple tree pollen in. So I make this serum based exactly off your test results so I can give you the best result possible. It is a totally customized therapy.
This is so wild. And then how does it work? Because again, going back to food, right? Oral immunotherapy is kind of like my reference.
Yes.
It's a process, right? You got to come in, they sort of like escalate the dose. It's under very strict supervision. We're watching for anaphylaxis. What's the parallel for that in environmental allergies?
Yeah. Okay. So there's two ways to work it. If I'm doing subcutaneous, I'm giving you shots. I start by making the top dose. So I make the strongest stuff. I dilute it down 5 times and I give you the weakest stuff. And every week you come in and I slowly increase the concentration of the allergen that I'm giving you so that over time, your body desensitizes to it and you develop a tolerance to it. Okay. So that now when you're playing outside in the spring, you're okay seeing those pollens and your body isn't completely hyperreacting. There is always a risk and a benefit to everything that we do in medicine. The benefit to allergy shots or sublingual immunotherapy for environmental desensitization, the benefit is that I can desensitize your system and help you create a tolerance and help you feel better. The risk is anaphylaxis. I am giving you, an allergic person, exactly what you're allergic to. So in the worst case scenario, you could have a severe allergic reaction, anaphylaxis, to that therapy. For that reason, after every allergy shot, the patient waits in the office for a half hour so we can monitor them and then they can leave if they're feeling fine.
Is there a risk of somebody who has an environmental allergy to have to have anaphylaxis, not from therapy, forget immunotherapy for a second, but just like out from exposure. If I'm allergic to dust or pollen and I'm exposed to dust or pollen, is there a risk of anaphylaxis?
It's a very rare risk.
Okay.
It's very rare.
How does that compare to the risk of anaphylaxis during immunotherapy for those things?
During oral immunotherapy, you mean for the food?
For environmental, either through the shots or sublingual.
Oh, okay. So the shot is also a very low risk, but definitely higher than what you're seeing in the environment. Okay. So there's,
Okay.
I tell my patients it's very rare to have a severe allergic reaction to a shot, but it exists. We see it. The sublingual immunotherapy, that's where we make your serum, we dilute it, and then you take it under your tongue. The first dose, it's little drops.
Mm-hmm.
And you take the first dose is given in our office, but you can do this therapy at home. So it's
Okay, so the risk sounds much lower.
It's much lower, which is why you can do it at home. It's we do give you an EpiPen, we teach you how to do it, but it's like a much sort of kinder, gentler way of doing things in terms of it is safer and it is much more convenient because you could do it at home.
I was going to say, so why would anybody opt for subcutaneous?
Okay, because the subcutaneous is the standard of care. It's been around a really, really long time and insurance will pay for it. Sublingual insurance will not pay for. So there's that aspect of it.
Right.
Did you say yet?
Yet, I'm right. I'm assuming it's evolving. And if it's more convenient, it's
evolving. And in fact, there are some products that are approved by the FDA already. They're sublingual tablets that you could take at home. They don't have great insurance coverage. So that comes back to the yet in your comment, right? Like one day we will get better coverage for this, but there's a ragweed tablet, there's a grass tablet, and there is a dust mite tablet. The issue is when I make your serum, I can treat you for everything all at once. When we do the tablets, it's like you can treat for one thing. That's what we know about.
So I think that does go back to your point about testing and how there is a utility for testing if someone, right, it has severe symptoms and we need to know exactly what to put in their serum if this is somebody that's going to go to immunotherapy. It sounds like, right, a lot of allergy stuff is sort of convenient in the sense that treatments many treatments are over the counter. There's immunotherapy that you can even take at home. Fortunately, or maybe unfortunately, there's also testing that you can do at home. Talk to me a little bit about home allergy testing, because I see ads for this everywhere. And there's a lot of attention to it. I get a lot of questions from families about this. My general approach is I don't think this is a thing, but talk to me about your view on it.
This is not a thing. Your general approach is correct.
Okay.
Who knows what that is? It's like, I don't know, did they go on Shark Tank or whatever, but this is not like FDA approved testing. It's never anything I would recommend. Occasionally a patient will come in with, they did this hair thing. Like they looked at the hair follicle. I'm like, that is like, I don't know, maybe that's something that will be here in the future. It's definitely not validated testing. I have literally no use for that kind of test. So for me, that is, I wouldn't spend my money on that. I don't know how it really gives me an answer that I could trust. And that's another thing. You always want to be able to trust and validate your test. And I don't know if those tests are really that trustworthy, to be honest.
That makes sense. This is ultimately a preventative health podcast. So what I try to remember to ask when I can, whenever I speak to specialists, is what's like a nugget or a pearl in terms of preventative health that applies to your specialty that you just like wish people knew. That might be hard for an allergist, but I feel like there's got to be something.
I know you already did the food talk. Okay, I know you already did it, but my biggest pearl really is regarding that because food allergy is such a big issue, and that is feed your baby. We always say that in my office, just feed the babies because they have to eat these foods. They have to eat these highly allergenic foods with an emphasis on egg and peanut at the age of 4 to 6 months. So you've probably already covered all of that, but that is actually my biggest pearl is just feed the baby. And then my second pearl, I would say, preventative wise from allergy, sometimes parents will ask me, well, I'm allergic. Should I test my child? And the answer is you really don't have to. Like if your child is not exhibiting symptoms, we don't need to test them. And so, sometimes the kids develop it and then we test if appropriate, if necessary. I don't know if there's really, I wish I could give you an answer to actively prevent allergy, to actively prevent asthma. I will tell you one thing, that when you asked me about like, why would you do shots over the sublingual? And
Yeah.
we've talked about that a little bit. One other thing that shots can do is they can help prevent the development of asthma in an allergic child. So that is actually something that we can do to help prevent the atopic march. And by the way, any sort of desensitization, whether it's sublingual or through shots, is a long-term therapy. So shots are usually given for 3 to 5 years.
Oh, wow.
And the sublingual will do for several years also. Now, the hardest part with shots with the desensitization is the first year because you're building up over that year. But then we space it. So you're coming weekly for many months, but then we space it out to every 4 weeks. But we do the whole thing for 3 to 5 years.
So it's a big commitment. So
Yes.
it really needs to be, I am guessing it needs to, a good candidate for this type of therapy is someone whose allergies are really affecting their life.
Yes.
And they're either not responding, right? Like you were
Yes.
saying, right? They're not responding to the usual therapy, or they're just not interested in it and they just would prefer this and are ready for the commitment. But I don't want to downplay it. It really seems like
It
it's
is a big
time-consuming.
commitment. And I actually tell my staff, like, we talk about allergy shots like a conversion. Like I really want you to know what you're getting into. Like this is a huge deal, right?
Yeah.
Like it's a major time commitment. You have to get into my office, you have to wait a half hour. And so some people will say to me, well, is it easier when the kids are older? It's actually not, because everyone's lives get really
Yeah,
busy
they have
as they get
stuff. They have
older.
after school activities.
Yeah.
That's what I'm thinking for like a school
Mhm.
age kid. This is like it's a whole thing that they have to commit to.
It's a whole thing. And so, but the thing is that it's the only thing I can do that is what we call disease modifying. Everything else is a Band-Aid. I can get to the root of the problem with shots. And so when you have a kid who suffers, and we put you on shots when you're in elementary school, then you're great playing your outside sports by the time you're in middle school and high school.
Yeah.
So there is benefit.
What's next in allergy? What are you looking forward to in terms of development, technology, or new things on the horizon?
Mm-hmm. A lot of the research in allergy is not going into environmental allergy. Let's start there. People are always like, I've been using this Allegra for years. Isn't there something new? I'm like, not so much. We have a lot of those same kind of drugs. I would say there's lots of research on the asthma front. There's lots of research on the food allergy front. And, in general, our field of allergy and immunology is going more and more and more towards biologics. And so these are these very tailored drugs that really get to the heart of the immune system, to try and really make significant change in a patient's life. So we are using a lot of these drugs in our more severe asthmatics, as an example, like you may have heard of them, Xolair, Dupixent, Nucala, Fasenra. These are all injectable medications that we can give for our more severe patients.
Okay, amazing. I want to thank you so much for your time. This has been great. I think love allergy more than I've ever loved allergy after two back-to-back allergy episodes. And I appreciate the challenging but really amazing field that you're in. So thank you so much.
Thank you. Thank you so much.
Thank you for listening to the JOMA podcast. We welcome your feedback and ideas for future episodes. Send us an email at health@joma.org. Don't forget to subscribe, rate, and review us on your favorite podcast platform.